And at the end, there'll be some questions. So this is an IEC standard related to usability. There's a lot of words on there. There's words like manufacturability, there's risks, there's normal use, assess, mitigate risks. There's a lot to take in there. I'm not exactly sure what anyone's supposed to do with this, because your job now is to take the interpretation of that and actually make something. And you'll be happy to know that the FDA has a crisp 49-page document related to human factors that you can refer to that sort of says the same stuff. So we're going to do a little something different today. So how many of you have actually been in a surgery? Okay. How many of you have observed a device that you designed in that surgery? Excellent. How many of you have had an instrument that you've designed, you're in the surgery, and have had that instrument thrown at you during the surgery? We got one. Okay, we'll talk to you later. So that makes two of us. That's a real story that I'm going to tell you a little about because it relates to the development of the surgical technique. So I counted the number of surgeries that I've been in the other day. It's over 1,000 procedures. The majority of them are orthopedic, endoscopic, MIS procedures. And I've designed a fair number of devices. They've generated a fair amount of revenue. That's right. All in R&D roles. That's me. So back to the story. This is as simple as a device as you can possibly imagine. It's a suture-passing device used in shoulder arthroscopy. You move the little lever and the little flapper at the front goes up and down, captures suture. The front is pointed to go through tissue, grab suture on the other side, pull it back through. So I was in the procedure watching this being used, and in the morning, everything was great. The surgeon was, this is a terrific instrument. It was an evaluation of the instrument. It had just become sales released. We were free to use it. We were getting confirmation that the design was safe and effective, and it actually worked. In the afternoon, the surgeon became very, very frustrated. And that's when the incident occurred, where the surgeon removed the instrument from the surgical field forcefully, and it got launched across the room. I was a lot more nimble back then, so I was able to avoid it. And I did pick up the instrument, and I squirreled it away and took it home. So what happened? Same surgeon, same surgery, same operating room, same operating staff. This is what happened. In the morning, the patient was in a lateral position, and the instrument functioned perfectly. So the surgeon could hold the instrument, move the little lever, do everything they needed to do. Lunch comes, afternoon comes, we're in a beach chair position. The surgeon was trying to access the patient from the superior portal, and he couldn't quite convolute the wrist to get the instrument to work. So on the surface, shoulder arthroscopy, same surgeon, same staff, same procedure on the docket. It's pretty critical to know the patient positioning when you're designing the instrumentation. So that is kind of the theme of this talk here, about all the elements that are all interrelated to success. I got 3 high points I'm sure you're really excited about. One is, you really want to be a small part of a procedure, sort of like a referee. It's like you don't want to be part of the event. You want to enable but not be in the way. So once questions start and discussion begins, time starts going and frustration levels rise. So you want to enable, you want things to go well, but you really don't want to be a big part of the event. So these are the 5 aspects that I've distilled down to think about as you're developing your devices and techniques. I've covered patient positioning pretty well, I think. It comes back at the end. And there's also, you need to access the joint space, you need to be able to see something once you're in there, or the space in the anatomy, you want to be able to do something. You want to take something out, or you want to fix something. So you're resecting or you're repairing. First up is access. Back to the story. This is the standard portal positioning for a shoulder arthroscopy. There's a cannula in the top that essentially is a placeholder that gets you in and out of the joint space consistently. There's a standard arthroscope, and the arthroscopic shaver is being put in percutaneously. There's no cannula, but it's being put in directly through the skin, and essentially off you go. For minimally invasive knee surgery, there are 3 standard portal positions. It's a little more, well, it's critical in all areas to have these, to know where the portals are, to know where the surgeon puts them. As an example, if those inferior lateral and inferior medial positions are too low, you're going to have to contend with a tibial plateau to do something in the back of the knee. If they're too high, you're going to have to navigate the femoral condyle to get around where you want to be to access what you want. If they're not, the surgeon is very reluctant to make new portals because that's additional stab incisions, trauma, problems. You don't want to do that. So what they do with rigid instrumentation is they start to do something called levering. So they enter the joint, and then they start to apply force with their hand to navigate the anatomy to get where they need to go. So one of 2 things happens. One, the skin incision gets a lot bigger. Actually, 2 things always happen. Skin incision gets a lot bigger, and you can damage cartilage with that levering. And you won't even see it because you're not looking at that particular part of the joint because you're interested in a different pathology, but back here, you're damaging the femoral condyle. So the positioning and access of these things is pretty critical. In laparoscopic surgery, there's, in the abdomen, to pick an area, it gets blown up with carbon dioxide. And that does a couple of different things. One is it separates the skin from the organs for additional portal placement safely after the first one's inserted. And 2, it provides space. There's a relatively large amount of space to deal with in the abdomen once it's blown up. Large patients with a high BMI, it can get fairly large, so your instruments have to be able to access in that situation. The pressure that's in the abdomen needs to be controlled. That's a box outside the operative field delivering a certain pressure over a certain amount of time. If it's too high, it can affect the breathing because it pushes on the diaphragm. So you need to understand what's going on outside of the sterile field when you're accessing the patient. You can lose pressure in a number of ways, and you can lose the pressure through the shaft of your device that you've designed if there's enough clearance in there for the CO2 to escape. So you'd be fighting the pressure, even though your instrument's in there, the surgeon may not realize why they're losing pressure. So you're fighting that during the procedure. I like the picture on the left because it shows 2 surgeons and 5 hands. So that's a pretty accurate representation of what goes on. There's a lot of moving parts to these procedures. It's very complex. You got someone holding the scope. You might have someone holding the brass gun, and the surgeon's doing something else to triangulate to a particular anatomy inside the abdomen. And on the right is a fairly standard setup with 4 cannulas with the scope, and the insufflation is one of those tubes. Fairly standard setup. Visualization, and I pulled these images just off the internet, just on Google, and they thought one looked interesting. This one's interesting because while this setup looks really crisp and efficient, that monitor is quite a ways away from people that need to see what they're doing. And companies spend millions of dollars on image quality to be able to identify different tissues, to get the lighting right. These things are very expensive, and then they put the monitor like in a different zip code in the operating room, and they expect the surgeon to be able to do that. Now, it might have been just for effect, but I've seen this happen where the surgeon is actually squinting to see the image of what they're working on, and the camera company is like cringing and saying, why do you set up this way? And you put so much effort into this. So the setup affects a lot of things, including visualization. Standard arthroscopic scope, we've got 3 different angles. Typically, there's some products coming out that are smaller and they're articulated, and you can see different angles. They're not quite there yet. There are some helpful hints. Down on the lower right, there's a little arrow on that image. That's the direction of view. So that is the direction that the camera is actually facing. And that's if you don't know that, it's important for the orientation of the surgeon. So it's a visual cue for the surgeon to know which direction that they're looking, because they're concerned about all kinds of different things, and they want to know what they're actually looking at. So the camera companies put that little angle, that little triangle in there to show the direction of view. Some other technologies that are certainly worth noting. Ultrasonic guidance is another form of visualization. It's sort of like a MRI/CT image of, in this case, a needle going into a vessel. And there's a local company called Active Surgical, which is doing some pretty interesting stuff, where you can actually see the degree of perfusion in an organ and see the blood flow on the screen. So actually check that out. Number 2, when you Google and you see images of videos of procedures, everything looks very big. It looks like the size of a Volkswagen on the screen. You don't have that much room, especially in very tight, constrained spaces. So be aware that although it may look large on the video screen, it's actually, you don't have that much real estate, and real estate is always an issue when you do all that stuff. And it gets back to that leveling and positioning, all that. You don't want that. Repair. So you've set up the patient, you've accessed the joint space, you're seeing inside the joint. Now you want to do something. So one of the 2 things you're going to do is repair. There are a lot of devices that are out there that are sort of in this kind of tissue repair segment. The interesting part of repair is that typically the technology is now inside the patient, and you get to take it home with them. So they end up with an implant, or they end up with something, or a treatment that there's a whole other set of criteria that you have to meet in terms of biocompatibility, long-term implants, sterilization, shelf life, all that stuff. All that stuff enters into play because it's not short-term patient contact anymore. It's long-term because we get to take it off. There's profiles like that distal radius traction plate. If that's too high of a profile, it's going to be, the patient's going to feel it, and it's going to be very uncomfortable. You may have to go in, it causes irritation. You may have to go back sooner than you want to have it removed. The N-Fix RC, that's a fairly new development from a company called Tempus. That is a bone reinforcement implant that aids in suture anchor placement for the pull-up on the shoulder. So osteoporosis, you can have your bone is essentially like an eggshell, where it's very hard on the outside but soft on the inside. And this overcomes that at the tendon bone interface. It's pretty interesting stuff. And then delivery instrumentation is critical. So There are a number of technologies, companies have come out with products that work great, but how do you deliver it? And that gets back to the whole technique thinking. I had a client yesterday where I was explaining this whole process to them because they were dead focused on one particular thing in the procedure. And we asked a series of questions to broaden their thinking to ultimately achieve success. It was very nice. Resection. So none of these stand alone. The repair segment needs resection to get rid of tissue that's in the way of visualization. But you have mechanical resection, you have power mechanical resection, you have RF ablation. RF ablation is pretty interesting because you can deliver energy and ablate tissue in a fairly small amount of real estate. You don't have jaws opening, you don't have scissors and punches that have to articulate and move. The energy is delivered in a fairly small diameter, so it's a pretty significant area. I put the arthroscopy cart up here because all of those things have to work together, but they can't interfere with each other. So you get EMI interference, you get ESD, you have all kinds of elements that occur. So you have to make sure all the equipment works. So if you introduce something new, you need to understand what's there. And you need to make sure that, again, you don't become a big part of the procedure. You want the instrument to work, you want the box to work, but you don't want it to, you don't want to turn on an RF device and have it scramble your monitor. Not that that ever happens, but it does. My last helpful hint, which we go home disappointed. Everything that we work on are enablers, but they also can distance the user from the patient. Surgeons go into medicine to be part of the patient procedure, element, experience. So everything that gets introduced, you don't want it to get in the way of what they're trying to do. So I couldn't do this presentation without touching on surgical robotics. It's a ridiculously hot topic. There's all kinds of suppliers here with robotic parts everywhere. And it's amazing technology. It's intended to increase the amount of dexterity, to do complex motions once you're in the joint space. Some of the issues that it still has, tactile feedback. That means if you push with a certain motion, you feel that motion back in your hand. And if you remote in another country and doing remote surgery robotically, it's really hard to do. So tactile feedback is critical because certain tissues have certain feedback, and that's not good tactile feedback. And some companies are working on it, and it's understood to be a challenge. You need a very trained staff with very low turnover to be successful long term. If you have 2 people coming and going every couple of weeks, it's really hard to set this system. And you can see the setup involved. It's complex. It's a ridiculous enabler. However, the same 5 aspects still apply. So you have the surgeon that's focused on the resection and repair. The rest of the staff is focused on everything else. They're setting up the patient positioning, they're setting up the access, they're setting up the visualization. So if you're working on an element of a robotic procedure and you're focused on the motor and the control of that motor, consider all of these aspects as you do that, because they all have an impact. So all of these come together to enable a successful minimally invasive procedure. No one stands alone, and no one is more important than the other, because I can come up with countless examples of where one wasn't quite adequate to enable something else. They all mesh, they all come together. You can organize your use cases like this. You can organize your FDAs like this. You can have the setup, how we're going to do that. Your team will say, wow, we're not involved in that. We don't make products like that. Yeah, but that's pretty important for the success of what I'm doing, so we need to know these. And if it's not an issue, great, but at least it's not. So that's the end of what I'm going to talk about. If you have any questions, just kind of the moral of the story here. Just take a step back sometimes. Think of really what you're trying to do. Think of what the user is trying to do. Think about the patient. Think about those kind of elements, how they all interact, and how they're all related. Thanks, folks. You have a question? Yeah, come on up. Yes. Mm-hmm. Yes. Okay. Excellent question. This is the first question. The question was, how is visualization kind of achieved effectively in arthroscopy? One thing that I forgot to talk about, I'm glad you asked that question, is a thing called fluid management. So there's saline that flows in and out of the joint space, and that does two things. One is it equalizes with the blood pressure to keep any blood out of the visual field, and two, it removes debris that gets in the way as you're accessing the space and moving tissues around. So fluid management is very critical to, and it gives you some distension, and in some arthroscopic procedures there's actually something called distraction, especially in hip arthroscopy where the leg is actually pulled to give you a couple of millimeters more of space to work, because the hip is a very tight joint. So fluid management is a pretty significant key, and there's usually a problem with the fluid management because either the pressure is, if the pressure is too high, there's a thing called extravasation, and that's where the fluid goes to places that you don't want it to be. So if it's in the knee, it starts going up to the thigh, you're not operating on that. You want it to stay within the knee joint. So you need to make sure that it's stopping the blood flow, removing the debris, but not leaving the space that you're actually operating. So fluid management basically. Anyone else? Thank you for coming over, KJ. Frustration. Yes, we'll call it frustration. Yes. Yep. Yes, I can. So this, my story with the suture patch, there was actually a couple of different versions. We were using a line of low-cost inline handle devices. So what we did was we targeted those for that position. So for surgeons that use a lateral decubitus position, this is the instrument for you. And we already had a line of what's called a pistol grip. So you grasp it like this, and comes out like that, and that worked clearly for the beach chair position. So we didn't discontinue the line because we knew there was value, and they cost about a quarter of the other ones. So there was some margin to realize, and we knew they worked in a certain customer segment, setup segment. So that's how we targeted it. And you can also use it in other procedures where they require it. So you could use it in the ankle, and you could use it in the knee, no issue. So that's how we manage that situation. Thank you. All right. Oh, wait, number two. Yes. Mm-hmm. Yep. So the question of intended use, and that's a very carefully worded term, is it actually means something. And it's actually different than indications for use. You can Google that. I'm not going to go into that. It's very strange. So we did not change our instructions for use, which contains the intended use, because you could still use the instrument that we designed in that procedure in a lateral position, just using a different port. And the surgeon can quickly figure that out. Say, oh, I can't access up here, I'll just use that port here. So we didn't have to go through a major change to either the indications or the intended use. Words. Yeah, there's words in the IFU, and then the marketing collateral that's probably the features and benefits, and we work on that. Okay, I think we have exhausted the audience. All right, you gotta leave now. Thanks, everyone.